Thank you very much, Charles, for that kind introduction. Good afternoon, colleagues, and thanks to the London... I practiced, Liverpool School of Tropical Medicine for inviting WHO to be part of this. So for this keynote, I plan to talk about a topic that is very dear to my heart in maternal health. When one takes a closer look at maternal health today, you all agree that maternal health is in crisis, especially when you look at it from the global perspective. If you're looking at it from the UK perspective, you might think everything is rosy. But when you look at it collectively, it's really disturbing. I take it that many people in the room are interested in maternal health, and you probably will have heard some of the things I'll be talking about today. But I'm going to try to spin it in a different perspective so that I can convince you to maybe do something different from what you're currently doing. So in the spirit of the theme of the session, which is challenges in maternal health and innovations, I'll be talking about global maternal health crisis and what we have been doing as WHO over the last couple of years around postpartum hemorrhage to sort of suggest some solutions. Why am I saying 18 minutes of my time? I just started talking. Okay. So let's go, down the memory lane a little bit. I'm sure you all agree with me that maternal health is a barometer of societal health and its level of inequality. For several years, maternal mortality has been the key tracer of health systems in terms of health system functioning and in terms of its performance. Since the 90s, global health leaders have all been sort of coming together to set different agendas. You're all aware of the MDG5 agenda to reduce the 1990 maternal mortality ratio figure from about 380 per 100,000 live births to 95 or thereabout by 2015. And the entire world went into this Safe Motherhood program. We did several things back then. And we managed a little bit to reduce maternal mortality by, say, 44% by 2015. But since 2015, what happened? In 2015, world leaders came together again to set another agenda for another 15 years. And we said, we want to now reduce maternal mortality ratio globally from that baseline in that 2015 to less than 70 per 100,000, okay? Good ambition. But what happened? From what WHO and its partners released in, I think, just about last year on the maternal mortality estimates, it was quite disturbing to see this picture where in the last 5 years of the report, from 2016 until 2020, there was absolutely no progress. So for someone like me who's been in WHO for the past 11 years, this is my school report. And it means that I failed. We all think in our small corners of our offices, we're doing the best job. But when you look at this figure, you have to ask yourself again, am I really making impact in what I'm doing? And then, you have to start thinking, what kind of explanation can we offer for this flat line that we're seeing in the last decade, actually? You could say, well, things are, going as usual. But I think that at least my own theory is the fact that we're living in a different world than we were in 2015. The world is totally different in many ways. Take the environmental impact, for example. We're all talking about climate change. You've seen what has happened in the UK over the past couple of days. It took divine intervention of some sort for me to be able to land at Heathrow a couple of days ago. But when you look at, climate change, what is happening with climate change, the economic impact around the world, in terms of growing inequalities, shrinking health budgets, COVID-19 came and disrupted many things for several countries, and they haven't recovered even up till now. What about politics? Political strife, insecurity in several places. Look at what is going on in the Middle East right now. People are still getting pregnant and giving birth in those settings as well. Thinking about what we call all the isms: nationalism, isolationism. It's very difficult to pronounce. Extremism, all sort of ideologies that people want to think about themselves, me kind of attitude. And what is that leading to? That is not how it used to be 10, 20 years ago. It's getting worse. So we're operating in a totally different environment, and we need to acknowledge that. But unfortunately, we're still using the same whole techniques that we were using back during the MDG era. But not everything is wrong. Technologically, there's been a lot of advancements, and we should have been able to sort of tap into that to sort of make the most of, advancement around maternal health. So there's, AI. There's a lot of prospects around AI, precision health, different things. But on the flip side of that as well, there is disinformation, misinformation, all sorts of things that sort of go with that. So let's look at some numbers to see, to sort of bring home what I'm trying to say here. So in this chart, you see that way back in the 80s, maternal mortality, in terms of the absolute number, was around 500,000. Like 500,000 women were dying every year. And we did a bit to sort of improve on that. But if you look at what has happened over the years, look at sub-Saharan Africa. Most of the changes that we have seen over the years have actually happened in South Asia and maybe Central Asia. But Africa has more or less remained the same in terms of the contribution to the absolute burden of maternal death. So this is what I was talking about before. I mean, we all hear about, maternal mortality ratio, global burden, but when you actually dissect where these problems are happening, the contributors to the maternal mortality burden are just a handful of countries. From the 2020 estimate, 65% of global maternal death burden is just happening in 10 countries. Just take a minute to think about that. 10 countries. And in fact, 29% of that is coming from one country. That's Nigeria. 5 of these 10 countries are in what we call the obstetric stage transition number 1. So the usual suspect in terms of this contribution have been known for years. We all talk about it, but we do very little about it. When we want to do our research or we want to do some implementation or scale up, we go to countries that are easy, where things can easily be done. But we ignore some of these countries that have been suffering from this situation for a long time. If you take those 10 countries that I sort of put out from the latest estimate, and you look at what has happened to the absolute burden of maternal mortality over the years, since the 80s, you will be shocked that none of them had anything that disappeared. In fact, Nigeria continued to increase because the population also continued to increase. But for several of these other countries, you will have expected one of them to just sort of taper out if it's not contributing much. But the story is not that. What about economic levels? So there's cross-regional differences across in terms of maternal mortality burden as well. If you look at low-income, middle-income, high-income countries, substantial variations exist in the burden of maternal mortality by these income groups. While only 13% of the world population live in the least developed countries, this group accounted for close to 42% of all maternal deaths that happened in 2020. If you look at a similar kind of slide since 1985, you can see the thin line there for high-income countries like 1% from the 80s. So the picture more or less remained the same. You and I are working tirelessly every day on maternal health. But this is the picture we're seeing. This is the ultimate outcome of all of our efforts. What about money? How does money contribute to maternal mortality? Rich countries tend to have lower maternal mortality ratios. And in fact, from this picture, the size of each of the bubbles constitute the population size of the countries. As countries get richer, the maternal mortality ratio also gets lower. If you look at India and China, for instance, as their GDP per capita increases, the maternal mortality ratio also reduces. There are outliers, of course, because it's not just about money that contributes to maternal mortality. The United States, for instance, is a bit going in the opposite direction, despite the fact that it's getting richer. You know, Puerto Rico, similar in the same situation, and as well as I think Cyprus. But when you look at the overall trajectory of this, the richer you get as a country, the lower your maternal mortality ratio. So money speaks in terms of reducing this burden of maternal mortality. What about the concept, just looking at this again from the concept of obstetric transition. So obstetric transition, or what some people now call maternal mortality transition, is the kind of natural shift or natural shift in the maternal health patterns that you see as countries get richer and they have better socio-developmental programs. So in the series that we published earlier this year, this was the paper 1, where we sort of divided the transition of the various countries by the maternal mortality ratio, from very high maternal mortality ratio to very low. And using the same concept, just to think, over the last 20 years, how have countries performed in these different stages of transition? And I highlighted those countries that are the top 20 countries with the highest maternal mortality ratio and in terms of absolute number of maternal deaths as well. Look at where they are in terms of the transition over time, since 2000 to 2020. Very few of them moved from that stage to another stage. In fact, the entire world, out of 185 countries that we looked at, only more than, I think 121 out of them failed to shift from one stage to another stage. That should be disturbing. One area that we always forget, because we work in our comfort zones, when we do our research, we travel to places that are safe, that are secured, but we forget that 25% of the entire world population is living in an area that is fragile in terms of security, in terms of political stability. And people still get pregnant and have babies there. So when you look at all this, for instance, the WHO Eastern Mediterranean region is the area of focus. So Yemen, Iraq, Afghanistan, Somalia, and the likes are in that zone. And you can see the number there. 730 million are living there. 500 million women, people live in the countries that OECD categorized as the top 40 multidimensional fragility index. And 120 million of those people are actually women of reproductive age. And they're giving birth to about 20 million babies a year. That's quite a lot. So how did we find ourselves here? one thing I mean, as a champion of maternal health, I like to say this, whenever I can. Maternal health is not a single disease entity. It's not a disease in itself. But are we really doing ourselves, some kind of disservice by not promoting or flipping it from the angle of a disease condition? I know you have a department of tuberculosis, department of HIV, but do you have a department of preeclampsia, or department of postpartum hemorrhage, or department of sepsis? Those are also disease conditions, and they kill people. So if you look at maternal health in terms of contribution, all of this money from less than 10 billion to 40 billion recently is going to HIV, TB, malaria. Maternal health is still less than 15%, over this period of time. So we decided to sort of redo the way we're doing things. So we picked postpartum hemorrhage as the first item, being the leading cause of maternal death. And rather than just talking about postpartum hemorrhage under the umbrella of maternal health in general, we want to sort of elevate it as a disease condition. And just to drive home the point, if you look at the changes that have happened over the years in terms of contributions of postpartum hemorrhage to maternal death, why maternal mortality burden generally has been reducing since the 90s, the proportion or the contribution of hemorrhage has more or less remained the same. The other culprit is preeclampsia, has remained more or less constant over the years. But let's focus on postpartum hemorrhage for a bit. We did a back of the envelope, not so dirty calculation in terms of projections to 2030, what's going to happen if we continue business as usual for postpartum hemorrhage. What will happen is that indeed, by the end of 2030, we will have had many more postpartum hemorrhage cases compared to 2020. And in fact, we're going to have additional 6,700 deaths compared to 2020, between 2030 and 2030. And this additional death will mostly be happening in Africa, as you've seen from the previous slides. So WHO invited 136 or thereabout stakeholders to Dubai last year to just talk about postpartum hemorrhage. What are we going to do in terms of developing strategic directions across 4 strategic areas? So we got people from ministries of health, professional associations like FIGO, ICM, ACOG, FOXI, academic researchers from different institutions, including those in the UK, private sectors, non-governmental organizations, and the likes, to sort of just sit down for a moment and think about postpartum hemorrhage alone. And that was motivated by a number of things. First, I mentioned the fact that postpartum hemorrhage, is a deadly condition that contributes substantially to maternal mortality. But also because in terms of research, not much has happened in that space. Many of us, we got a PhD on postpartum hemorrhage, but what contribution have we really made? Over the last 30 years, there have just been 2 medications. One is stable carbetocin, and the other is TXA. Both of them are not entirely new drugs. They are more or less repurposed for treatment. Whereas in HIV, in malaria, in many other areas, there are always newer things coming up. We don't have that. And then the guidelines are all over the place. We're using the same evidence base, but we're coming up with different recommendations. So NICE says something, RCG says something else, FIGO says something else. And we are confusing the people at the receiving end. And lastly, multidimensional implementation barriers. And we've not been advocating as we should. I mean, look at what happened during COVID. Look at what, people in HIV, in malaria, TB world. There's a global fund for HIV, TB, malaria. There's no global fund for maternal health. How important is it? So we looked at these 4 strategic areas I mentioned before: research, norms, implementation, as well as advocacy. And this group of people came up with a roadmap in terms of what we will be doing collectively between 2023, when this was done, until 2030. Because there's so much confusion, so much competition For someone like me sitting in WHO, everybody comes to me from time to time. I have this gadget. How is it going to get into recommendation? I don't know. You know? How can we all sit together and agree these are the kind of research we want to do, these are the things that we want to focus on? So we published this roadmap. It's in 6 UN languages now that sort of set out these parameters. So if you're going to do anything on postpartum hemorrhage, if you want to invite WHO to be part of it, please check this roadmap. If it's not there, we'll probably not participate. And this just gives a kind of a quick overview of what the roadmap looks like from 2023 in terms of research, norms and standard, implementation, and advocacy. The idea is that we do meaningful research, impactful research, they translate to evidence, we implement those innovations or whatever implementation barriers they're trying to overcome, and then we advocate for postpartum hemorrhage as well. I'm going to run very quickly through this other slide. It's very complicated, but if you look at the right column, what are we trying to achieve with the 4 critical areas? So from research, we want to ensure that all the priority questions are answered. We want global guidelines to be consistent. So we're working with FIGO and ICM now to consolidate all recommendations on postpartum hemorrhage so that we speak as one. And then priority implementation bottlenecks to be overcome, regardless of the context that they might be, and to also advocate a lot to sort of raise funding for postpartum hemorrhage cause. And all of these strategic areas are interconnected. So you do the research fits into the guideline then, supports adaptation and adoption of what people should do at the country level, and then advocacy as well. But very importantly, it's also quality of medicine. How do you make sure that that countries are procuring quality assured medications for treating postpartum hemorrhage? And of course, at the end, we want to be able to sort of review what we've done, see how much we've covered, and see how we can move on with that. I just put this slide. This is all available in the roadmap document itself. Some of the research priorities have been addressed already. However, you can see there's the green bars for the cross-cutting questions, innovation areas, and the yellow bars there. These are ongoing studies. But the implementation one, that tends to be the major bottleneck. There is nothing happening at the moment. So if you're interested in starting any research on postpartum hemorrhage, these might be areas that you want to look into. But as part of a demonstration, as part of the proof of concept that we really mean business this time around, WHO acted, as soon as an impactful research was published last year, within 6 months to release a recommendation that relates to that particular intervention. And that is on the postpartum hemorrhage bundle. 2 quick recommendations for those who are interested that came out along with that is that you have to measure blood loss for every birth. It just doesn't make any sense that we define a disease quantitatively, but we then don't measure it. And secondly, to apply the bundle when if a woman bleeds up to a certain limit. We, as I mentioned before, we've now developed an MOU with FIGO and ICM to consolidate all recommendations on postpartum hemorrhage. And we had a meeting last year to sort of define what the recommendations or the guidelines will include. What we should be anticipating from WHO in this space next year will be things that I have on the screen, the consolidated guideline, training materials, a WHO academic course, as well as what we call implementation toolkit. As part of the roadmap, we had the call to action as well for 9 categories of individuals. I'm not going to run through the details of all of them, but everybody in this room has a role to play when it comes to this particular condition. So from women's group, the international community itself, in terms of having a much more coordinated and unified initiative around advocacy, Ministries of health, in terms of ensuring there is coordination, there is also strengthening of leadership in the space. Implementers to develop new approaches, increase advocacy on postpartum hemorrhage, form coalitions with government and professional organizations, professional associations to support different collaborations, training of their members, and promoting adherence to recommended interventions, guideline developers to use similar evidence base to come up with similar recommendations and be consistent. Some of these things are already happening, as I mentioned before. Researchers like yourselves to execute research that are meaningful, industries and innovators to work on what is going to address public health needs and make commodities more affordable and accessible. And donors to, of course, pull in more funding. On one of our websites, we have this, what we call the PPH roadmap tracker. If anybody wants to sort of follow up to see how this is moving in terms of the agenda, you're very much welcome to do so. So here's I think it's my last slide. Not to leave you with some kind of doom and gloom view of the future. There's a lot that we can do to sort of, improve the situation. So I really like this slide that was put together by Max and I forgot the name of the other person now. But if you sort of look at where we would be, if you look at the current situation today, if today was like the past, when maternal mortality was high everywhere, and this was using data from Sweden and Finland back then, when maternal mortality in the 1800s was like 900 deaths per 100,000 live births, we will actually be having 1.26 million women dying as of today, okay? If we remain like that. However, what we have today is a little bit different. So you could say the world is a little bit better, but it's not that great either when you look at at what we have. So, what about if we compare the best region of the world in terms of maternal mortality ratio? If everybody can have that level of maternal mortality ratio, so Australia and New Zealand region is like 4 per 100,000 live birth right now. Imagine everybody having that. That will give just 5,600 deaths. I said just with quote and unquote there. But it's much smaller than the 287,000 that we have now. And if we maintain that rate, we will have saved approximately 1.7 million lives. Just think about that for a second. So if we work differently, if we work in an impactful way, we have a potential to change the current trajectory. So that's my last slide. Thank you very much for listening.